Hello, my name is Anna Neumeier. I'm an assistant professor of pulmonary and critical care medicine. Clinically, I practice at Denver Health, where I'm the associate medical director of our ICU. And I will be presenting today this just-in-time learning on an introduction to mechanical ventilation management. Beginning with disclosures, this session is part of a learning series funded by the Administration for Strategic Preparedness and Response. The content is a product of my work and does not represent a policy of the U.S. government. The information is designed for your learning, but is not a substitute for medical advice, diagnosis, or treatment. I personally do not have any relevant financial interests or relationships to disclose. Let's review the learning objectives. By the end of this session, you will be able to contrast indications for invasive and non-invasive mechanical ventilation, describe the basic modes of mechanical ventilation, assess respiratory mechanics as they relate to the physiologic aspects of patient-ventilator interaction, and identify when a patient can be liberated from the ventilator. Mechanical ventilation for this session will refer to invasive mechanical ventilation, which is a form of respiratory support, defined as the delivery of positive pressure into the lungs via an endotracheal tube or tracheostomy tube. During mechanical ventilation, a predetermined mixture of air, known as the percent oxygen, is delivered into the central airways with pressure. That air flows to the alveoli of the lungs with the goal of helping the delivery of oxygen, achieving the goal of oxygenation, and removal of carbon dioxide, achieving the goal of ventilation. The indications for mechanical ventilation can be defined more broadly by the indications for endotracheal intubation, as there are reasons to intubate and support a patient with mechanical ventilation that extend beyond respiratory failure. And a helpful way to conceptualize this is using the ABCDE framework. We intubate patients for airway protection, meaning to protect against impending airway compromise or swelling, which can occur in the setting of anaphylaxis, angioedema, airway bleeding, or perhaps an airway tumor. We, of course, and certainly intubate to support a patient's breathing, patients who have rapidly increasing oxygen needs or worsening carbon dioxide due to respiratory failure, due to conditions such as pneumonia, acute respiratory distress syndrome, status asthmaticus, or severe COPD exacerbation. For patients in severe circulatory failure and shock, we intubate patients as supporting their respiratory muscles reduces their metabolic demand, which is important during shock states. Additionally, in the setting of disability or impaired consciousness, we intubate patients to help when they are unable to protect their airway, and we intubate them to prevent them from aspirating. And additionally, E stands for everything else, such as intubating in the operating room or intubating for urgent procedures. In summary, the decision to intubate a patient and place them on invasive mechanical ventilation should be due to conditions that are not quickly reversible with conservative, normal supportive methods. And your clinical judgment is key, meaning if you suspect a patient needs to be intubated, it's better to intubate them early rather than attempt additional supportive devices and risk them suffering deterioration. Invasive mechanical ventilation is a form of respiratory support that is in contrast to non-invasive ventilation, also known or referred to as CPAP or BiPAP. Non-invasive ventilation has a therapeutic role to treat pulmonary edema due to heart failure exacerbation or hypercapnic respiratory failure and increased work of breathing due to COPD and asthma exacerbations. And a general rule of thumb in approaching when to use non-invasive ventilation is to use it for quickly reversible conditions that will improve within 24 to 48 hours. With medical therapies, with the recognition that invasive mechanical ventilation becomes your treatment if non-invasive mechanical ventilation fails. Similarly, CPAP and BiPAP should not be used if the patient is altered, unable to protect their airway or their secretions, if they have recent upper airway surgery or facial trauma, or if there's an untreated pneumothorax. All right, let's discuss ventilator modes and settings. The ventilator mode and settings determine the amount of pressure or flow that will be delivered to the patient. And the selection of the mode and settings is guided by therapeutic goals. These include oxygenation, ventilation, patient comfort, and settings to facilitate weaning. How the lung or the respiratory apparatus responds to ventilation is influenced by lung compliance, which is described by the equation compliance equals a change in volume over the change in pressure, meaning that lungs with low compliance that are stiff due to disease will need high levels of pressure to achieve small changes in volume. In general, you can think of ventilator modes falling in two general categories: volume-targeted and pressure-targeted modes. In volume-targeted modes, this is what we use most often. It's also referred to as volume control. A predetermined volume is selected and delivered to the patient, and the pressure that results or is achieved is variable, determined by the compliance of the respiratory system. In pressure-targeted modes, the converse is true. The pressure is set, and the volume of the lung expansion is variable. In addition, each mode has three features. The trigger is what starts the breath. This is often time or patient effort, meaning if there is a desire to have the patient breathe at least 12 times per minute, then a breath is delivered every 5 seconds, where the time trigger is 5 seconds. Additionally, the patient could receive an additional breath by generating a negative pressure or a change in flow, which will prompt the ventilator to give an additional breath for that patient. What ends the breath is known as the cycle, and this is the target of the mode that is set. Meaning if it's a volume mode, it's the targeted volume, and if it's a pressure mode, it's the targeted pressure. Similarly, there's also a limit. Once again, either volume or pressure, which is the point in the ventilatory cycle where the ventilator will not apply more volume or pressure because the target has been reached. We can use the arterial blood gas to remind us of the parameters that we're targeting. The efficiency of ventilation is measured by the patient's pH or their PaCO2. And to augment those, we can control the tidal volume or the respiratory rate. To control oxygenation, that is influenced by the inspired percent of oxygen, the FiO2, as well as the mean airway pressure, which is the pressure transmitted to the alveoli. This can be increased by increasing PEEP. As you see, these targets can be reached by either ventilatory mode, and no mode is superior to another. So it's important to understand the pros and the cons of each and what to monitor depending on the mode. So let's discuss volume control in further detail. As a reminder, with volume control, every breath delivered is the same set tidal volume. On the right-hand side, you can see some ventilatory waveforms. On the top is the pressure waveform. On the middle is the flow waveform, and on the bottom is the volume waveform. In a volume control mode, the breath is delivered until the target volume is reached, at which point flow stops, comes to zero. And the pressure, which is in the lungs, starts to return to the preset base point, which is the positive end expiratory pressure. In a volume control mode, the trigger is time, the target and cycle limits are volume. You set the respiratory rate, the tidal volume, PEEP, and FiO2. And you must monitor the pressures, which are both your peak and your plateau pressures, to ensure that the lungs are not receiving excessive pressure, which can cause injury to the lungs, known as barotrauma. The peak pressure is measured with each respiratory cycle, and you can see it at the top of these respiratory cycles. The plateau pressure is a static measurement that's performed with an inspiratory hold, and we'll discuss this more later. Now let's look at pressure control. Looking at the example of pressure control, the pressure is set and the volume is variable. Looking at the pressure waveform, when the peak pressure, also known as the inspiratory pressure, is achieved, the flow is continued but slows. There's a set duration of time that pressure, that inspiratory pressure, is held, at which point it stops and the flow returns to zero. During that inspiratory pressure hold, the volume of the lungs will continue to increase or expand, and the volume achieved is variable and dependent on the compliance of the lungs. In pressure control, the trigger is time, the target and cycle limits are pressure. You set the respiratory rate, the inspiratory pressure and time, the PEEP and the FiO2, but you must monitor the tidal volumes, recognizing that in patients who have dynamically changing lung compliance, you could have significant changes in tidal volumes achieved at a given pressure, and this in turn can impact your minute ventilation. The final mode that we should discuss is pressure support. This is a spontaneous breathing mode that's used when patients are approaching extubation, where they will generate their own respiratory force and receive a little bit of support from the ventilator to assist with the work of breathing. In this mode, the trigger is the patient's effort, detected by a change in pressure or change in flow. Then a pre-specified pressure is delivered, and once that is achieved, the flow will stop. This mode is a spontaneous breathing mode. There's no control over minute ventilation beyond that of the patient's control. Now, it's important to recognize that when we place patients on pressure support, we will always have a backup control mode in case the patient develops apnea, they become too sleepy and they're not breathing on their own. So there's always a safety in place, but in general, this is a spontaneous breathing mode that we place patients on as they are approaching extubation. Now that we've reviewed the modes of mechanical ventilation, let's discuss the modes. There are threefold goals of mechanical ventilation. The first is to maintain oxygenation, in which case we target an alveolar oxygen level greater than 55, which is around a saturation of 88% or greater. The second goal is to maintain ventilation with a pH above 7.2 with as low possible of respiratory rates. As you see, the goals of these numbers is not to achieve physiologic normalcy, and instead, guided by years of randomized controlled trial research, the greatest important goal of mechanical ventilation is actually to minimize lung injury while the patient is on the ventilator. Lung injury occurs through three mechanisms. The first is barotrauma, too much pressure to the alveoli. The second is volutrauma, too much volume to the alveoli. And the third is atelectotrauma, which is the opening and closing of the alveoli with every respiratory cycle. Therefore, we use what we call lung protective ventilation strategies, which is maintaining low tidal volumes, and in the case of acute respiratory distress syndrome, ultra-low tidal volumes, where we're targeting 6 cc's per kilogram of ideal body weight. And we maintain alveolar recruitment using positive end expiratory pressure. So, to review, what changes do you need to make to increase ventilation? This can best be described by the alveolar ventilation equation, which states that the alveolar ventilation, which is inversely proportional to your PaCO2, is proportional to your respiratory rate and the tidal volume subtracting the dead space. So to increase pH and to reduce PaCO2, you either need to increase your respiratory rate or increase your tidal volume. Additionally, physiologically, if you're able to increase your mean airway pressure and recruit more alveoli to participate in gas exchange, that in tune will optimize your VQ matching, which will also improve your alveolar ventilation. Let's think about oxygenation. What ventilator settings do you need to increase oxygenation? You can increase the amount of delivered oxygen, which is the fraction of inspired FiO2 or the percent FiO2, or you can increase the PEEP, which will increase your mean airway pressure. Additionally, in the cases of severe hypoxemia or refractory hypoxemia, you can institute therapies to reduce the patient's oxygen consumption. This includes the use of sedatives or neuromuscular blockade. So let's put it all together, walking through an illustrative case to discuss the principles. We have a 67-year-old man who presents to the emergency room after 1 week of fever, cough, and dyspnea. On exam, he is tachypnic, his respiratory rate is 35, he's hypoxic, his saturation is 85% on a 15-liter non-rebreather mask. His nasopharyngeal swab and PCR returns positive for influenza A. Based on his chest radiograph, you diagnose acute hypoxic respiratory failure and acute respiratory distress syndrome due to influenza A. And you decide to, these are your options. A, clinically monitor, no change in oxygen therapy. B, add a nasal cannula to the non-rebreather for additional FiO2. C, start non-invasive ventilation on a BiPAP setting of 12/6 with 100% oxygen. Or D, intubate. The best answer here is intubate, and this is a reminder of our ABCDE conceptual framework that in a patient who has rapidly progressive oxygen settings due to conditions that are not rapidly reversible, the best therapy is invasive mechanical ventilation. So what might the initial settings look like? So in a patient who we are worried about acute respiratory distress syndrome, maintaining the small volumes in the lung protective ventilation is paramount. So the mode that would be chosen in this circumstance would be volume control. The tidal volume would be set to 6 cc's per kilogram of predicted body weight. The respiratory rate should be set to match that of the patient's minute ventilation before intubated. And then in general, we'll start with 100% FiO2 and a PEEP of 5, and then we'll titrate both the PEEP and the FiO2 guided by the ARDS-NET PEEP scale. And this was generated by multiple randomized controlled trials published by the ARDS-NET Research Foundation, which helps guide us the optimal PEEP and optimal FiO2 rate settings. So this patient ultimately settles out on volume control with a tidal volume of 470, respiratory rate of 28, FiO2 of 60%, and a PEEP of 10. Recognizing that 470 for a 6-foot tall man that predicted body weight comes out to be for 6 cc's per kilogram is 470 tidal volume. Let's move on. After 30 minutes, the patient's ABG comes back with a pH of 7.12, PCO2 of 75, PaO2 of 65. Thinking of the current settings, which are vital volume control of 470, respiratory rate 28, FiO2 of 60%, PEEP of 10, what changes would you make? Would you A, increase the FiO2 from 60 to 80%, B, decrease the PEEP from 10 to 8, C, increase the respiratory rate from 28 to 32, or D, increase the tidal volume from 470 to 550? The best answer here is to increase the respiratory rate. And the reasons is that this patient has a respiratory acidosis, so we need to increase his minute ventilation. Therefore, we could increase either respiratory rate or tidal volume. However, it's important to prioritize respiratory rate over tidal volume to maintain the tidal volume of 6 cc's per kilogram if possible to minimize that volume drop. Once you've implemented these changes, remember, in a volume control mode, it's important to monitor airway pressures. The peak airway pressure, represented by this equation, is the total pressure of the respiratory system and is the sum of the resistive pressures, which is calculated by the flow times the airway's resistance, and the compliance pressures, which is the volume of the lung times the elastance of the lungs, plus the positive end expiratory pressure that is set. The peak airway pressure is measured with every respiratory cycle, and you can set alarms for that. However, the plateau pressure must be measured by directly stopping flow. When we stop flow, we remove the contribution of the resistive pressures to the total pressure that's measured. Normally, there is a less than 10 centimeters of water difference in pressure between the peak and the plateau pressures. And anything higher or a greater difference than 10 suggests that there is a resistive pressure issue. If the plateau pressure is elevated, defined as a plateau pressure of greater than 30, that indicates that there is a problem with compliance of the respiratory system. Let's explore this further. Going back to our case on hospital day 2, the nurse calls because the peak pressure alarm is going off. How might you figure out what's going on? And so in this case, you see on the ventilator waveforms that the pressure is high. And so the next step is to perform the inspiratory hold, where we learn that the peak pressure that was reading out as 35 is well above the plateau pressure, which is only 20. So a peak minus plateau of 15 is high. Anything above 10 suggests that there's a resistive issue. So your differential for increased airways resistance, as you're interpreting your ventilator mechanics, includes whether you have an obstruction in the ventilator circuit or the endotracheal tube. Perhaps the patient is coughing or biting the tube. There could be bronchospasm in the airways leading to increased airways resistance, perhaps a mucus plug that's causing obstruction, or a foreign body. Let's look at an alternative scenario. What if the ventilator looked like this? Meaning there's a high peak airway pressure alarm, an inspiratory hold is performed, and the peak airway pressure, while high, is 40. The plateau is 35, meaning the greatest contribution to those high airway pressures is your plateau pressure. Remember, high plateau pressure suggests a compliance issue. Causes of reduced compliance of the respiratory system include main stem bronchus intubation, meaning mechanical ventilation to one lung with a volume that is intended for 2 lungs, pneumothorax causing increased intrathoracic pressure, acute respiratory distress syndrome, pulmonary edema, reducing lung compliance, auto-PEEP, which is a scenario in patients who have airways disease where there's still a certain amount of pressure that's less in the thorax at the end of expiration, large volume ascites or abdominal compartment syndrome, recognizing that abdominal pressures or thoracic pressures, and in the case of chest wall rigidity, can also contribute to high plateaus. All right, let's move forward in the case. It's now hospital day 7. The ventilator settings are now volume control of 470, respiratory rate of 20, FiO2 of 40%, and a PEEP of 5. Can the patient be extubated? So as patients improve clinically, we start to think about extubation criteria, and this is important to keep in the back of your mind and have knowledge of. So the criteria for extubation include the first, that the underlying process or the reason for intubation has improved. The second is that the patient is on minimal ventilatory support, typically 40% FiO2, 5 of PEEP. Their mental status, their strength has recovered, manifested by a cough, a gag, ability to follow commands or raise their head. They should have manageable secretions. And then finally, we have them complete a spontaneous breathing trial, where they breathe spontaneously on pressure support settings that are minimal, inspiratory pressure of 5 over a PEEP of 5, on minimal oxygen for roughly a half hour to 2 hours. And if they're able to maintain relatively high total volumes and low respiratory rates, that can meet criteria for extubation. So in summary, as a reminder, the indications for mechanical ventilation and intubation can be summarized using the ABCDE framework. When you're setting your ventilator modes, you can either choose a pressure-targeted or a volume-targeted modes. Your parameters should be guided to maintain ventilation as well as oxygenation. And to do so, to maintain ventilation, you should adjust the tidal volume and respiratory rate. And to maintain oxygenation, you should adjust the FiO2 and PEEP, while ensuring that your settings are minimizing barotrauma, volutrauma, and atelectic trauma. In volume-targeted modes, you must monitor the peak pressures. And if you have high peak pressures with normal plateaus, that suggests an airways resistance issue. And if you have high plateaus, that suggests a reduction in the compliance of the respiratory system. And you should remember the differentials there. Thank you very much for your attention and for viewing.